Good morning. Welcome probably to the best session of the conference. It's a pleasure to kind of moderate this session. I am Manu Shankar Hari from UK, and my co-chair is...
My name is Libo Bos from Amsterdam.
And the first speaker is Dr. Rubenfeld from Toronto. He's going to tell us about, is it time to abandon the consensus definition of ARDS and sepsis?
Thank you. Oh, my slides made it. That's always a good sign. Good morning. This morning I'd like to be a bit provocative. So I'm going to tell you that the answer to this question is yes, but in a qualified way. So I have some conflicts of interest. I guess the most important one is that I've been a part of these activities, and despite the conclusion, I think, of my talk this morning. So the story begins in 1967, and I hope this is a paper that everybody here has read. If not, walk right out of the conference and go and read the paper by Ashbon Petty, because I think you'll probably learn more about ARDS from this paper, at least than you're going to learn from my talk. It's a classic paper that not only describes the syndrome that many of us take care of. I'm going to tell you that much of the things that we've spent the next 60 years or more, or so, learning about are all in this paper. They kind of predicted them, studied them, thought about them in this paper, including the dreaded viral ARDS called COVID, although there it was just viral pneumonia. After this was initially described in the 60s, in the 70s, people started seeing ARDS kind of everywhere. The problem is they called it something different. So instead of studying ARDS, we had a plethora of papers with lots of different names. Some of these I personally have never heard of, but apparently there was lots of papers written about these. And there's a lot of confusion about what people were studying. Are we studying the same thing? Are we studying different things? But it felt confusing in the literature, mostly because people were basically all around the world were studying their own version of what Ashbon Petty had described and calling it something different. And so relatively soon thereafter, John Murray and Michael Mathey developed a score to try to help organize some of this mess. And I think this score is still really helpful in terms of thinking about the variables that go into determining how sick someone is and what, if you will, what type of ARDS they have. Although not technically part of the score, you'll see that part 3 of this classification scheme includes the risk factor, which of course, as we'll talk about a bit, is profoundly important in thinking about how you're going to treat a patient with bilateral infiltrates and hypoxemia that is in heart failure. So I think it begs the question of who really cares about a definition for ARDS? Like, why do we need these rules? Does it matter? Does it matter if you're taking care of a patient? I'm going to tell you there are only 3 reasons that we might need rules to follow in taking care of a patient that we might think have ARDS. One is that you at the bedside need to figure out and calculate or decide, does this patient meet these specific criteria because I've got a treatment that I know I can use in patients who fulfill these criteria. I'll let you think and ponder for a minute for all of those specific treatments we have for ARDS and raise your hand and tell me. I can tell you when it comes to lung protective ventilation, which of course is the great, if you will, innovation of the last 50 years, we know from LungSafe that doctors apply this basically based on how sick and how low compliant your lungs are. The more hypoxic and the lower your compliance are, the closer you get to delivering lung protective ventilation. So even in that, we're not really, and I'm not sure we should, by the way, be strictly only applying the Berlin classification to delivering plateau pressures under 30, et cetera. The other reason is researchers need to follow rules. This one is crucial. If everyone out there who's a researcher is kind of coming up with your own rules to study, and you publish a paper and you say, well, we use the modified Rubenfeld criteria in our paper, I don't know how to replicate that study in my hospital in Toronto. So it's absolutely crucial, not only that we're following rules, but we're following rules that are reliable. So when I follow the rules, whatever they are, I actually identify the same patients in Toronto. This is absolutely crucial. So rules and rule following are not just important for trialists, they're important for anybody who wants to enroll a patient that they want to write a paper about and say, I studied ARDS. And if not, we're going to go back to the mess that was the 1970s. So you can tell I think this is an important one. Finally, there are some diseases that we either get paid for, or we get penalized for, maybe not in your country, but in other countries. This usually applies to certain infectious complications where we have rules to follow. Other than these three things, there aren't any reason to follow strict rules. And I'm going to tell you of these, particularly for ARDS, where we're still exploring effective treatments for generic ARDS, the following of reliable rules is absolutely crucial. So how does this process of coming up with rules, how does it become kind of political? And I'm going to use that word specifically. And the reason is we don't really have any rule police. We don't have anybody who says, well, if you don't follow these rules, then these bad things are. And then we might end up with lots of rules. We'll have, 22 consensus definitions. We'll have a European one, we'll have a North American one, and then we'll be back to sort of a mess. So the only thing that we have that's kind of close to rule police, we do this a little bit with our evidence-based guidelines too. The only thing that we have close to that are our professional societies. So these consensus enterprises to generate rules that researchers can follow so that we're kind of doing the same thing, it becomes a political enterprise and you sort of get the professional societies and voila, that's how you end up with consensus conference rules to follow. Soon after the initial description of ARDS and you've got the MATHE score and people are writing papers at least about ARDS, comes the next debate. In this debate, pay attention because we're still playing out this game and it's the lumper splitter game. And it's the no, ARDS is a thing. We can study this ARDS thing, and it's interesting and important. And you've got other people saying, well, that's ridiculous. ARDS is not a thing. We've got community-acquired pneumonia. We've got hospital-acquired pneumonia. We've got patients with pneumocystis pneumonia, COVID pneumonia, lots of pneumonias. I take care of trauma patients with bilateral blunt traumatic injury. They have ARDS. These are all different patients and different things. That's stupid to lump them. So lumper splitter debate. Pay attention. We now call it the endotyping debate. It's the same debate. It's an important debate. Don't let my tone imply that it's important debate. But it's an old one. Okay. So we have these political consensus conferences. These are the first few. The last one, I'll just point out, led by Neil Ferguson, wasn't, it was a bit of a side stream. It wasn't professional society, if you will, politically motivated, but it was methods motivated. These investigators said, hey, you know what? It's nice when you have a consensus conference that the consensus isn't just the loudest person at the table. By the way, that's not the definition of consensus. There really are methods to developing consensus, and Neil Ferguson and colleagues in this paper actually followed one of the methods to develop consensus. So the latest one, gosh, I can't believe it's this long ago now, the Berlin definition, with which you're all familiar, made some smallish improvements, got rid of some terminology that was confusing, this acute lung injury terminology. It allowed for identification of non-invasively ventilated patients, but it was a bit of a mess. You have to be kind of a language scholar to figure out what the heck Raniere meant when he wrote the terminology for non-invasive ventilated patients, so that needed some fixing. And it tried to provide some training materials. So there was a draft definition and a final definition. I'm going to talk more about this draft definition. Pay close attention to that lower right corner where it talks about an incorporation of compliance and sort of a poor measure of dead space. You say, well, I kind of like that. I wish they'd included those variables. I don't remember seeing compliance and kind of a dead space measure because it was the draft definition and it wasn't the final definition. I'll talk about how we made the decision between those because it's about the only novel thing that was done in that. People hated this, well, lots of people hated this definition. And people said, well, why where's the biomarker? Where's lung water? Where's CT scanning? Where's the troponin for lung injury that I wanted? Well, none of that was in there. This is terrible. Because this is what we wanted. People, I think our consumers, which is all of you, wanted us to come up, this is the way we don't diagnose, this is the way leukemia is diagnosed now. You've got nobody has AML. People have specific genetic markers in it. We wanted this for ARDS. What we have now is kind of the way leukemia was diagnosed in 1976. 1976, the way you diagnosed leukemia is you looked at a slide and there were lots of little blue cells, or they weren't so blue, they had segmentations in them. By the way, when pathologists looked at those slides, they couldn't agree necessarily which ones there were, which is the same problem we have with x-rays. So leukemia in 1976 was kind of a syndrome. People looked at slides and they classified them based on the way these pictures looked. And they've evolved, and we haven't. So what we wanted when the Berlin definition came out was something that looked like, that looks like AML with genetic abnormalities and biomarkers and lung water cutoffs. But what we have is something that looks like looking at slides and telling how many little blue cells there are. And the reason we don't have that is because we don't have the science to do that. We don't have the science yet to do that. It just isn't there. So we may want it, but we don't have it. So what we do have, and the science, if you will, that was in the Berlin paper, was how we picked between this proposed definition, which sounded pretty good at the consensus, and a simpler definition that didn't include compliance and plateau pressure, or compliance and dead space. And we did an analysis called predictive validity that looked at how well they predicted mortality. And this is an analysis that's been now incorporated into the sepsis definitions. And I'm embarrassed to admit it all starts with me. It doesn't, but I wrote a paper a long time ago where I said that this is a way, since we don't have the science yet to do cool stuff like biomarkers and gene markers. We don't have that yet. There is a science to let us do better than we're doing, and I kind of laid out a framework for doing that. And that's kind of what we did. You're not going to be that impressed with this, perhaps. It's not as sexy as a gene marker, but this is what was done. We looked at how well these two different definitions predicted mortality. They both, this kind of refined one with compliance and dead space, identified groups that had about the same mortality as the simpler one, and there were lots more patients. And we picked the one that had more patients. And that was kind of the rule we laid out for doing it. And you'll say, wow, that sounds kind of dumb. There might be lots of differences between those patients just because they have the same mortality, the group that has lower compliance and different dead space. But that's what we did. We told you what we were doing, we laid out the framework, and it was transparent about why we picked the one over the other one. And believe it or not, that's what Manu, who's sitting right there, you can blame him for this one. That's what largely his analysis, trying to pick among the many possible definitions for septic shock, a very similar framework was picked for that. He was transparent about the methodology, told you what he was going to do, picked the one definition, and told you how, it wasn't him alone, of course, but he's here so you can blame him. Since it's bothered me for I don't know how many years, I'm going to fuss a little bit about the X-ray in ARDS because it's a mess, and we know it's a mess, and we keep ignoring the fact that it's a mess. And the reason is the only difference between a patient that you might say has acute hypoxic respiratory failure that isn't heart failure, all those patients who are hypoxic, whether they're intubated or not, who have bilateral infiltrates, or unilateral infiltrates for that matter, the only difference between those patients and calling them ARDS is what their X-ray looks like. And you might as well be flipping a coin for about probably as many as half of the patients who the question comes up. You might as well be flipping a coin. We tried to make it better in a large group of researchers who were enrolling patients in LungSafe. We did a randomized trial of some teaching materials that we thought were pretty good, and it had no effect on how much they agreed on the X-rays. So we know we have this problem. It's not a little problem, guys. It means that although we've talked about ARDS all the time, and remember how I told you that the main purpose of this is we're all enrolling the same patients. Well, we're all enrolling the same patients, except we're kind of flipping a coin on half of them. So if the X-ray matters in terms of predicting who's going to, respond to therapy or not, or who's going to have different genetic associations, who's going to have different immune phenotyping, blah, 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 if the X-ray affects any of that, in other words, if it matters, if it should be in the definition, we might as well be flipping a coin on a big chunk of the patients. So I think it's a problem. Nobody else seems to, but I do. So COVID's been so I think COVID has proven that endotyping is crucial. COVID is just a really simple endotype of ARDS. It's COVID ARDS, just like we have SARS ARDS. Is it the same as ARDS? Well, yeah, except it isn't, because it's caused by a single pathogen that does a lot of really complicated and interesting things, as many of you know. Is it different than ARDS? Well, in a whole bunch of ways, it isn't. We had some editorials at the beginning of the pandemic that argued, based on probably personal experience, that it was different. But it probably, now we have a lot of papers that say actually these patients look very similar, the vast majority of them, except they're younger and they stay on the ventilator a bit longer than some other groups. And we know that drugs that we thought might work in generic ARDS because of their immune modulatory effects work in COVID. So it is different. It predicts response. COVID, as an endotype of ARDS, predicts response to therapy. All right, I'm going to wrap up almost on time. So the future, does the definition need some tweaks? Absolutely. We need to fix the sloppy language. Many more patients, particularly after COVID, are being managed with high flow, many more being managed with helmet ventilation, non-invasive ventilation. We need to fix the language around that. I don't know about in your hospital, but we have many papers now showing that the use of arterial lines is much lower now in routinely monitored ventilated patients. So lots of patients aren't getting arterial blood gases. We have to have a way to say you have ARDS even if you haven't had an arterial blood gas. And we have that. We have lots of data now in the SDF ratio. And then we have this bigger problem that I've told you a little bit about around the imaging. So we tried to wrap some of this up, Art Slutsky and Marco Ranieri and I tried to write a paper that I thought was going to be incredibly boring, but has turned to cause a bit of a skirmish. All we said is, if you want to have a new consensus conference definition, and you want to say we want to come up with a better definition, you have to say what you mean by better. That seems pretty straightforward. The introduction of the paper ought to say, we think the old definition is bad, and this one is better because. If you're going to make some tweaks around a non-invasive ventilation and S/F ratio, I think you can do that with a well-written editorial. I'm not sure you need the rule police to enforce that. And then we said, in addition to telling us why, you have to tell us what your methodology is for establishing what better is. It's kind of boring, I think. We talk about what that methodology ought to be. Fine. We also kind of say the splitters win in a way. We say that one single definition for all purposes, the same purpose is to do a health services research paper or an epidemiologic paper on how many patients are ventilated with ARDS. You need a different definition than if you're doing a COVID trial. We think if you're doing a COVID ARDS trial, you ought to at least make sure the patients have COVID, okay? So we think that that's a perfectly reasonable modification of the ARDS definition. Manu has written a lot about this, and I unfortunately don't have the time to highlight some of his thinking around this early on. And this is probably what I think the future is going to look like. And a lot of smart people have spent the whole weekend thinking about this, so hopefully, I'm sure we'll have an answer to it. The future ought to look like this. We ought to have an umbrella definition that ignores the X-ray. Acute hypoxic respiratory failure, and not otherwise specified. That ought to be the umbrella definition to get into a study around acute hypoxic respiratory failure. And then we ought to have some simple, there are lots of obvious simple enrichment or endotyping. COVID is the most obvious one. And then we're going to start to have a lot of complex endotyping. And one of the one that's very sexy now, I call inductive phenotyping, where you take lots of variables from the patient and you let a computer cluster them into various. So this is probably what the future is going to look like. Thanks very much. Sorry for going over a bit.
You don't want to take any questions?
I thought you guys were going to punish me for going late.
We can have a short question if anyone wants to. If not, okay.
Oh, there was, see?
Yeah.
I knew there'd be somebody.
G'day, Craig Walker from Australia. I would just say, we're having another consensus about how we should redefine ARDS. What about just saying maybe ARDS isn't a thing at all? Yeah. It's just lots and lots of different things. And if you keep trying to lump lots and lots of different things into a definition of anything, you're just going to go round and round in circles. and it seems like we've been going round and round in circles for 50 years.
Yeah, you should wear a big thing that says, "My name is John Murray." All I can say is yes. And hopefully there'll be somebody over here who says that, no. It's a valid debate. The only thing that I'll say is, for therapies, other than lung protective ventilation, I would agree it's hard to find the therapy, right, treatments, pharmacologic treatments, that will treat a patient who has bilateral parenchymal, contusions, right, and somebody who has COVID pneumonia. It's hard to, other than a physiologic, support therapy, ECMO could be another one where it becomes, maybe not so important what the cause is. But getting the argument to get rid, that we don't even need the term anymore. If you'll notice, sir, that was the top of my umbrella, right? It was acute hypoxic respiratory failure. So I don't think it's a very reasonable argument that the term has sort of served its purpose. By the way, if somebody comes along and they want to make this better definition, I'm hoping they'll write an introductory paragraph, right, where they're supposed to tell you and me why it's better. They're going to tell us in that, what they've done in that paper to make it better. It doesn't look like you'll be persuaded.
I don't know.
All right, thank
had a-
you. That is the perfect intro for our next speaker. Dr. Marco Ranieri is going to tell us if a better ARDS definition is the answer, what is the question?
It's going to be very easy to give this talk, given the introduction that Gordon provided before. Now, as we heard, the issue of defining ARDS has been always controversial. And this level of discussion has been, if possible, even been increased by COVID-19 pandemic for a number of reasons that I will examine during my presentation. But the first one that is not listed in this slide is that for the first time we had a huge amount of patients with what was so-called ARDS. And even my mother was able to understand what the hell I was doing for a living after 30 years. Even my mother nowadays knows that ARDS exists because she saw it on TV, and everybody was talking about ARDS. You saw this slide. This is the first paper that reports the term ARDS. And what in this paper the authors concluded was they essentially identify a subset, an endotype, we would say nowadays, of 12 patients out of more than 250 patients, all with acute hypoxemic respiratory failure, that they were characterized by a number of clinical and pathological variables. And this was the basis that took off the term ARDS. Few years after the publication of this paper, at that time was American Review of Respiratory Disease, published two editorials, one from Thomas Petty and the other one from John Murray. John Murray say, ARDS, may it rest in peace. Petty said, well, I'm a pure lumper and I think ARDS should exist. Now that was few years after the publication on Lancet, using for the first time the term ARDS. Many years later, we got exactly the same picture. These are two editorials published in the COVID area, one saying ARDS exists and must be actually adapted to what we learned during the COVID-19, and another editorial saying, because of what we learned during the COVID-19, we should get rid of the terms ARDS. Now, if you see this pendulum of arguments keeping going, keep going, something that must be wrong in the basis of the logical process that led us to the concept of ARDS. But I want to, and this is in line with what Gordon said, I want to focus your attention on these words used by Martin Tobin that wrote a letter commenting our paper on the Blue Journal. And because Martin Tobin is a distinguished and well-known academic intensivist, and he challenged all this discussion we had in the last 30 to 40 years about the ARDS, saying, who cares? Who cares about that? The clinician at the bedside does not need an ARDS definition. And actually, it was quite provocative, and I don't want to get into this because he's not here and it's not correct to debate with someone who's not in the audience. But that's what he was challenging, the basis it was challenging. Stop with this crap. We don't need ARDS. Let's take care of the patient based on physiology. And I remind you that I started this enterprise as an applied physiologist. But let me answer to Martin Tobin's challenge, why we need formal definition and how we should create them. Now, the answer to the first question was already provided by Gordon, because it allows the inclusion of similar patients in research, which was a point that Martin later was dismissing as totally irrelevant. But I think we need clinical studies, and without an appropriate definition, without appropriate inclusion and exclusion criteria that can be used by anyone around the planet, we don't take our field forward. And to provide therapeutic and prognostic information to the clinicians, to the patients, to the family. Of course, there are also administrative elements, but I'm out of them. So, how should we create a definition for ARDS or for other syndromes? Now, I would start with this editorial by a psychiatrist published in the early 90s, where he described the process that psychiatric field took in order to define what they treat every day, and they treat syndromes. They don't treat disease as well as we do. And the words he used to describe the process was evolving from the great professor principle to the consensus of experts to a scientific system of categorization. And if you think about it, this is what happened to our field. We started with the great professor principle. We ended up with a consensus of experts, and we tried, and this was probably the most relevant contribution that the Berlin definition provided, tried to apply a scientific system of categorization. So this is where we should go. Now, as discussed before, there are a number of open issues with the ARDS definition. The fact that we should use oxygen saturation instead of arterial blood gases. The fact that we are using high-flow nasal oxygen that would not allow nowadays, based on the Berlin definition, to define a patient as having ARDS. The fact that the Berlin definition is problematic in resource variable settings because they need chest X-ray, arterial blood gases, mechanical ventilation is not always available, because due to the fact that chest X-ray may be problematic, and because it's very complex in some context, nowadays we have ultrasounding, because many are proposing the concept of getting rid of the ARDS definition and use hierarchical approach, the big umbrella, endotype, phenotype, all that stuff. But I don't want to enter this. I will not give any slide on any of these aspects. What I want to focus is, what is the methodology we should implement nowadays if we decide we want to work on the definition of ARDS. And this is what is about the article that we published a few weeks ago on the Blue Journal. All the article is based on 2 books. Most of the article is based on 2 books. The first one was published in 1987, and the second one is more recent, was published in 2012, 2014. And based on the concepts that were described in these books, concepts that have been implemented in many fields of medicine, that have been implemented in other fields of science, sociology, psychology, and others. We need to adopt some methods if the target is to develop a scientific system of categorization and provide a definition of ARDS that is based on science and not based on the consensus of the great professors. There are some concepts that we need to adopt and implement in our scientific practice. First of all, abandon the concept of syndrome and adopt the concept of constructs, and then systematically apply the concept of reliability, feasibility, and validity in order to provide a definition, understanding what is really meant by reliability, feasibility, and validity. Constructs is, in a way, is a philosophical concept, is, in a way, is to agree on the words, on the terminology, so that everybody is able to understand what he's talking about. Now, this may be irrelevant in some perspective, but is absolutely crucial. Let's say, how do you define intelligence? Intelligence can be defined in many ways. So if we don't create a common language that is able to describe intelligence, frailty, and so on, we're not able to communicate. And that's why many authors, in fact, as a matter of fact, say what we are used to call syndromes in medicine are, in fact, what psychologists call constructs. So constructs is a systematic exercise to agree on the language. Why the language is important? I don't find any other way to understand, and that's why I'm trying to propose to you the meaning of construct and the importance of the concept of construct using Confucius. Confucius' pupil was asking to his master, if they ask you what would be the tool that you as administrator of a Kidmon would use, what would you do based on your philosophy, based on your wisdom? Confucius says, I would make sure that words are used with their correct meaning. And the pupil said, why? I mean, you are the administrator of an empire and you care about words? And Confucius said, yes, because if words do not correspond to reality, it's impossible to create positive relationship among individuals. And I think this is the best description of what I mean and what we meant in our article. Now, let me go fast through these concepts. Reliability, in the context of assessing a new definition, is defined as the ability to say that patient A has the syndrome, and this is true for me, is true for him, is true for him, is true for everybody. So we are able to, again, the language is able to identify the same reality wherever you are, whoever you are. Feasibility means that you have to be able to use these criteria everywhere without any limitation. Of course, chest CT scan may provide a better signal-to-noise ratio in terms of identifying what we have in mind as ARDS than a chest X-ray, but we can't do it everywhere and every time. Validity is the capacity of a test, and we don't have tests to make the diagnosis of ARDS, or a definition, to capture what the investigator is actually looking for. Now, if you have a gold standard, it's easy. I mean, you assess the validity of your test or of your definition with sensitivity, specificity, and accuracy. That is well-established statistical tools. But when you don't have a gold standard to refer to, and we don't have a gold standard, still don't have it, you can empirically assess the validity in terms of predictive validity, where predictive is to predict in terms of outcome, to predict in terms to response of therapy. and I stress your attention to the and or, you can use phase validity to validate your definition. That is, we all agree that in our gut, using those words, we identify the same patient. We, the royal we, everyone, everywhere. Now, in that article, we concluded with a very busy slide table of what should the process be for approaching a definition of a syndrome, the definition of ARDS. But let me summarize some aspects. First of all, as Gordon said, we need to know when we approach this what is wrong and in which way we want to make it better. And this has to be clarified upfront. Now, we need to explicitly clarify the language we are going to use to describe the process. Now, who should provide a definition? If the language is crucial, who should provide the language? Since we want to move from the great professor idea to a scientific approach, the only way we should follow to provide an upgrade of definitions is through scientific societies, and not as individual groups of investigators. And the criteria that are used to create the panel that is providing this definition has to be transparent and has to be declared upfront, and should include all diversity along the multiple domains of diversity. And this doesn't have to be politically correct, has to be politically effective. And we should define as experts not just the clinical scientists, but also the clinical practitioners. And the group should involve both identities, should involve all healthcare professionals involved in the care of these patients, and should include patients and family representatives. Now, the validation process should start with the hypothesis that ARDS has X and non-ARDS does not have X. And we should clearly define the variables that we should investigate. But let's say we don't end up with any variables that is able to provide a sufficient predictive validity. We are left with phase validity, and there is nothing wrong with that. There is absolutely nothing wrong with that. Psychiatrists treated schizophrenia, successfully treated schizophrenia for decades using just phase validity to define schizophrenia. Phase validity is not, forgive me, a mental masturbation exercise. If we don't have A that identify ARDS, we should use phase validity. But we must do it following the rules that have been provided by other fields of science. And I said we should follow the triplet, no? Reliability, sensibility, feasibility. But we have to understand that there are trade-offs in this. Let's say you can get a definition that makes in conflict reliability with feasibility, then you have to choose. And you have to declare at the beginning that you give priority to reliability instead of feasibility. And validity is a continuous process. You don't end up with a definition that stays there forever. And there is nothing wrong in saying this is the way how I consider my syndrome, but we need to check in 2 or 3 years because it's an evolving concept. And that's a crucial aspect. Validation of a clinical syndrome is not a statistical exercise. There is no rocket science in terms of statistical model here. It's a clinical problem. And we need clinicians, and clinical scientists to solve this problem. So this is the paper, and let me conclude thanking a number of people. First of all, my co-authors, because it was an incredible intellectual exercise. I know it's going to be boring to read it, but for me it was extremely fun to write it. Let me thank the editorial board of the Blue Journal, the reviewers, because they provided an outstanding work. I mean, I've been doing this for years, but this has been one of the most exciting experiences in terms of the reviewing process. And let me thank Gianrico Carofiglio, who is a book writer, my schoolmate from Bari. I mean, in Europe he might be famous, in Italy for sure he is, that provided me the Confucio quotation. Thank you very much.
Thank you, Dr. Ranieri. Any questions? We probably have time for one question. Jean-Louis.
Thank you. Thank you very much. Thank you very much.
You're welcome, you're welcome.
Maybe I can shout. Thank you very much for a very nice talk. I agree with what you say. But as you know, I like personally to emphasize the distinction between definitions and criteria, because I think it can help to decrease a little bit the confusion around all these concepts. You pronounce the word definitions about 100 times, but I don't think you pronounce criteria just once. To me, ARDS has always been and will always be the clinical picture reflecting the presence of non-hemodynamic type of lymphedema or leaky capillaries type of lymphedema. But that's very long to pronounce, so that the ARDS is much shorter to say. But the ARDS will not change as such. Exactly like myocardial infarction has always been a myocardial infarction before troponin was developed, and even before EKG was available. Now, you may change the criteria, but at the cardiology meeting, I don't think people would say, let's redefine myocardial infarction. They may discuss new criteria. And that's what basically we have done with the Berlin criteria, etc. And that's okay, because science progresses and we introduce other tests and other techniques to support the lungs, etc. So all of this is certainly very welcome. But if you say that the definitions change over time, that brings actually some kind of drawback from the people you talk to. When I talk to my students, I like to start with the definition, and then I go to the criteria, as I do for myocardial infarction, for peritonitis, or for pneumonia, or many other things. What do you think?
I think, as a matter of fact, I think. No, I think that your interventions stress out the importance of the language we use.
Yeah.
You may be right, but as a matter of fact, we have been dominated by the concept of definition, and we use this word, and probably we should change the wording that we are using to deal with the issue of ARDS.
That's it.
But I'm ready to go through this, but
Marco, let me help you.
yeah, thank you.
I'm here to help Marco. What he meant to say, because Jean-Louis is right, and in the terminology, and the terminology is not that important, but here it is a little bit. What Jean-Louis is saying is the term that we use in the paper is a construct, because that's what all the other fields do. The construct of ARDS, let's take something you all agree on, heart failure. We have in our idea this construct of heart failure, right? You know, orthopnea, dyspnea, something about the left ventricle isn't moving the blood forward. It's a thing in our idea. We know it exists. Whether we have diastolic dysfunction or we know this construct of heart failure, it exists. And this is what Jean-Louis, the terminology that Jean-Louis was using. Like a heart attack, whether we have to push or not, this thing where the artery gets blocked, it exists. Oh, yeah, I don't think anybody have trouble hearing me? No. So Jean-Louis is right, and the terminology here is only important if you get caught up in these debates. And Jean-Louis is exactly right that what we've done is we've refined the criteria. But I do think the gentleman who asked the question, do we even need we need a construct of heart failure? Yeah, like we all know what that is, we nod our heads. But it's not a dumb question to ask whether we even need a construct of ARDS. I think we do, but that's what we're talking about. Like, do you have in your idea a mind of a patient, you know, that you look after this construct, it exists or doesn't exist, and then we refine these other ways of finding the patients in different ways and defining them physiologically. So the construct of ARDS is kind of what Ashbaugh and Petty were talking about. And what Jean-Louis is getting at is that what we've done over the years is refine these criteria. And again, for those of you that are yawning in the audience, because you take care of your patients perfectly well with or without these, I agree. But if you're enrolling patients in trials, you should not be yawning, you should be scared. And the reason you should be scared is because if you don't know that you're in, and this is the importance of reliability. This is this word, we're just coming up with words so that our field talks the same way as every other field. We want to make sure with reliability that when you're following the rules, you end up with the same patients. That's all. Yeah, I don't know if that helps, but it at least kept Marco from confusing you.
Thank you. As I said at the start, this will be the most exciting session of the Congress. So, in the interest of time, Marco, in the interest of time, shall we, do you want to?
Very short comment.
Okay, short comment.
The most important experience of this paper was to convince Gordon to put in writing what he has in mind. He was not able to summarize into a full paper.
Yeah.
Always needed Marco to help us speak.
Yeah. Thank you, gentlemen. That was fantastic. Could I invite the next speaker, Dr. Rocca Oriel, to discuss the need to expand the ARDS definition? I thought it was a criteria.
Thank you very much. I will try to be a little bit more provocative. Apologize for that. With the title that I think that we need to expand ARDS definition by incorporating some criteria that were not available at the time that ARDS was defined. These are my conflicts of interest. I have never been related with any ARDS definition or guidelines. But my bias is that I grew up as an intensivist with this paper. It's the first that I read. I'm sure that all of you know that, with all the limitations that it has. 12 is harmful, 6, 8 might be the same, maybe 10, whatever it is, but it's my bias. And my other bias is that when I teach ARDS to the students, I always show this chest X-ray and explain that the patient has fever, bilateral infiltrates, and hypoxemia, and I ask them, what's the patient diagnosis? And because I'm teaching ARDS, everybody says that the patient has an ARDS. And I always say to the students that the patient has a bilateral pneumonia that meet ARDS criteria, which is something different. They are not excluded one from the other. So we never should forget the causative disease that generates the ARDS, because the treatment of an ARDS due to pneumonia are completely different in terms of etiological treatment than the one that is generated by pancreatitis. I will focus on two different criteria that I really think that should be included in the next, as a criteria in the next ARDS definition. And the one that I want to show you or discuss is pulse oximetry. And the reason because I think that it should be included is because ABG is not available in all settings. In fact, every day more and more, we are taking decisions based on SpO2 without an ABG sample. SpO2 is completely non-invasive and it's continuously available. It's highly sensitive for hypoxemia and it's more readily available than PaO2, especially in low middle income countries where resources are limited. But of course there are another part, that we should take into account as well. There are a lot of situations in the ICU that could lead to error measurements of SpO2. We have also potential reduced accuracy in patients with skin dark pigmentation, and also it may lead due to lower accuracy measurements to misclassification for the diagnosis or the severity of ARDS. And if we measure an SpO2 of 96 and we divide by FiO2 and we have the SF ratio, in that case, we will have that the patient has a mild ARDS. If the measurement that we have in the pulse oximetry is true, the patient would be correctly classified. But if the measurement is not true because the real arterial saturation is 93, which is 3 points below the measure in the pulse oximetry, the patient would have a moderate ARDS. And in the other side, if the measurement is not reliable because it's underestimating the real arterial oxygenation, the patient would not have an ARDS. So the risk of misclassification is real. Despite that, and to try to analyze how ARDS could be diagnosed in low and middle income countries, the Kigali modification criteria was developed 5 years ago, and there are three mainly difference in the criteria that they use. The first one is that they use SF in spite of PF to diagnose ARDS. There was no PEEP requirement. They had no ventilators at these countries, so maybe it was impossible then to diagnose ARDS. And finally, they use ultrasound in spite of chest X-ray due to a scarcity of chest radiography resources in this setting. And if you look at the results, and we have to follow, I'm following Berlin definition criteria, no patients admitted of more than 1,000 patients admissions in Rwanda hospital met ARDS criteria. By contrast, when they use Kigali modification, 42 patients were diagnosed from ARDS. So the Berlin definition was likely to underestimate the impact of ARDS in these countries. The second point is whether high flow patients should be included in the definition. And after publishing the first report in adults in 2010, we realized that those patients who failed and were subsequently intubated remain more or less similarly hypoxemic after intubation, several hours after intubation, comparing the PF ratio that they have when they were on high flow and the PF ratio that they have when they were intubated. So we try to demonstrate that it's not only a question of PF. We try to demonstrate that those patients were, in terms of biological assessment, very similar. And we matched two different populations, one with ARDS criteria and other population treated with high flow and bilateral infiltrates who were similarly hypoxemic using a propensity score matching analysis, and we took blood samples of all these patients. And as you can see, the patients who were treated with high flow were very, very similar to those who were to ARDS patients in terms of several biomarkers, inflammatory markers, markers of epithelial injury, and markers of endothelial injury. But not only that, those patients who failed, after 24 hours of intubation, the PF ratio that they have was pretty similar to the one that they have when were they treated with high flow, suggesting that these patients who were on high flow, who otherwise would meet the Berlin definition criteria may be considered at least as mild ARDS patients. And we believe at that time, was 6 years ago, that these results would have important implications in clinical practice and in research, as they provide the rationale for diagnosing and treating ARDS in early stage of the course of critical illness before mechanical ventilation onset. So at that time, we believe that future directions of ARDS should focus on establishing new criteria that include these non-intubated patients as well. But not only that, because inflammation in these patients was also predictive for the need of mechanical ventilation, which is something that we have more recently seen in ARDS patients, that inflammatory patients that has a phenotype who was inflammatory was also predictive for mortality. So pretty similar results in two, at the end, I believe, similar populations, which the only difference was the way that we treat with high flow or with mechanical ventilation. And it has been also reproduced with standard oxygen. When they switch patients from standard oxygen to NIV, only 30% of the patients lose the criteria for ARDS. And if you take the three definitions and you assess mortality of these patients, the mortality was pretty similar. So another reason to include patients, because the biological background that these patients may have would be pretty similar. And Professor Ranieri also showed it in a population of COVID-19 patients that were treated with high flow, or with NIV and were switched to invasive mechanical ventilation. Only a few percentage of these patients increase the PF ratio above 300 and lose the criteria for ARDS. So the vast majority of these patients meet the ARDS criteria regardless the type of respiratory support that they were receiving. But we have to keep in mind that maybe the mortality is not the same, and this is what the reason that we say that should be considered as mild ARDS, because mortality of these patients who were treated with high flow was slightly lower compared to the patients that were treated with NIV and then switched to invasive mechanical ventilation. And we should never forget that the decision for intubation is an arbitrary decision based on clinical judgment of one physician. I'm sure that some of you have been dealing with patients with high flow or NIV during all the night, trying to do not intubate them, and then you leave the hospital, and then your colleague that arrives at 8 in the morning, fresh after sleeping all the night, decide that the patient needs to be intubated. So what is not reasonable is to think that 5 minutes before, this patient has not an ARDS, and after intubation, the patient has an ARDS, only because the patient has been intubated. Because the patient has been intubated because someone has decided to intubate it. Because there is no standard criteria for intubation. I'm sure that if I show you 2 different patients or 1 patient and I ask to the audience that who should intubate this patient, it would be like flipping a coin. 50% will decide to intubate the patient, maybe 20% will decide to put on NIV, and maybe the other 30% will decide to keep on high flow and see what happens in a couple of hours. So ARDS is not based on a clinical decision of a physician who is taking care of the patient. ARDS is a syndrome that exists or not exists, regardless the decision that you take at the bedside. And I want to finish my talk only with a few words about guidelines and personalized medicine. I really think that these 2 concepts are not in fight one with the other one. I think that we need guidelines because we need to provide general recommendations that we need to apply in each particular patient by individualizing the treatment. But we need the general recommendations. And in fact, we are evolving to the coffee for all strategy, 6 ml, plateau below 30, and so on, to a more personalized treatment, trying to keep driving pressure below certain limit, regardless the level of tidal volume that we have to use, titrating PEEP according to physiology, deciding when we should to switch to assisted mode, and this is something that we individualize at the bedside. But we still need to provide general recommendations for all medical community. And I also think that we should, and most of the chairmen are much more experienced than me in that field, but I'm sure that we need to include the concept of phenotyping patients also to decide which of these patients would benefit the most from any of the treatments that we are giving to our patients. But phenotyping is not so easy. And it's not a question of black or white, because most of the patients are in the gray zone. And Lieve showed in a very nice paper that in COVID-19 patients that maybe it's not a question of classifying this patient. It's not so easy. And finally, don't forget that what we observe in clinical trials is the average treatment effect of the whole population included in each arm. That may underestimate the benefit of some patients, or may underestimate the harm in other group of patients. So phenotyping which one, if you are in the blue or the white zone of the intervention arm, would help to really personalize the treatment at the bedside. So to conclude, I would say that I really think that an expanded definition of ARDS, including some of these new criteria that has been appeared during the last years, will allow us to an earlier definition and potentially make patients benefit from earlier treatment, and including the concept of phenotyping and physiological measurements will allow for personalization of the treatment of these patients. Thank you very much, and I will be happy to take any questions you may have.
Thank you, Aurel. Great presentation. Questions from the audience? If there are no questions, I have a short one. Can you comment on the inclusion of lung ultrasound in the definition? Do you think that is a good idea as well, or are you afraid of the consequences of having that in the definition?
No, I'm not afraid, but you are much more experienced than me. So I'm afraid about the answer, but I think that we should allow to diagnose ARDS everywhere in the world. And probably in terms of including patients in randomized controlled trials, this should be taken into account in terms that is not the same diagnosing ARDS by lung ultrasound or CT scan or chest X-ray. But this may not limit to include this new technique, or this, not new technique, but this new criteria in the definition of ARDS.
Okay, fantastic, thank you. So we are already about 20 minutes over time, so we're going to keep the next speaker short. Well, the next speaker is Dr. Seymour from the University of Pittsburgh. He's coming down. He knows a lot of difficult words that summarize whole sentences, so that will save us some time. And he'll talk about sepsis phenotypes. I think that's right on time after talking about all these syndromes.
Yeah, sure. So I will stay short. I actually think the fundamental problem is that half the audience just left, and I don't think that's me. It's because at least I hope it's not me, it's because they see the word sepsis in the title, and they think of themselves and the patients they take care of, well, I'm an ARDS person, and think about that. That's the flaw here. So syndrome's still useful. This is meant to have a question mark at the end instead of a statement. I do have some conflicts, and I hope this is a little bit of a fun journey we go on for the next 10 minutes or so. Okay, so many of you in the room have spent lots of time thinking about this. This is a priority of the NIH. There are too many challenges to solve, certainly in the roundtable that we had, but let alone also in this brief time period. And that's because in sepsis, we see patients like this. They both have the same label, the same term, and yet they're quite different in terms of their clinical presentation, the pathogen, the organ under threat, how sick they are, and what sort of problems they brought to the table. And yet we still give them the same name, and we still think that many of the treatments that we use ought to be the same as well. Okay, so it has come up in the debate from Gordon and others, this issue of lumping and splitting, and sort of they said, well, what's the question here? Not only with the big circle and the criteria or definition used to define the big circle, but also the circles inside. And so this is sort of one of my most favorite graphs that I think we've ever made, and it's in an appendix, so not many people get to see it. But that said, what it's showing is the exponential rise in subtypes in these conditions over the past 50 to 100 years. And really, it's impossible for our minds to keep up with this, that there might be hundreds of sepsis subtypes proposed, and in this case, this was in COVID. There was just, whether it was H or L or Elasens, these others, it's too much to even think about as a clinician. There are examples that might involve the transcriptome, organ dysfunction trajectories. All these circles down here at the bottom are what are so-called knowledge-based subtypes, where experts sat in the room and came up with clinical features that they thought grouped together, and then went to the data and saw whether any patients actually filled those buckets. Another example was this study, which I'm not going to spend more than 2 slides on, in which electronic health record data was used to find sort of clinically computable or identifiable groups, and then sort of reproduced, right? There is no validation of a subtype, but rather we were able to reproduce these groups in other data sets. They have different organ injury patterns, they have different sort of clinical trajectories, biomarker profiles, and associations with outcome. Okay. So there you go. However, I find this slide to be even more interesting because it gets at the issue of where are we headed and sort of what's the sort of current state in sepsis, at least. And if you could think about the left, the Rothko being where we started in the 90s with sort of sepsis and septic shock, we've moved from the Mondrian to the Kadisky to now the Pollock on the right, where there's just sort of confusion about what patients are where, how they overlap, how do the groups and subtypes overlap. This was briefly touched on in a piece where we got the word phenotype anarchy in JAMA, but it really came from our colleagues in taxonomy. They've been thinking about this for 300 years, if not longer. It could be land snails, fungus, the platypus. Some of you have heard me talk before. We could find almost lots of examples where how groups are split really impact a lot of important things. So we briefly, mentioned sort of hypothetical scenarios. What if you have a set of, let's say, gorillas in, Central Africa? There may be a particular amount of interest both in them, funding, right, for huge conservation efforts around that species. But if that species becomes 5 more species, it becomes very complicated and political very quickly. In the same way that if you change a sepsis definition, it's not just for the clinicians, but now we saw this in Sepsis 3. Regulators and payers said, well, what happened to severe sepsis? This has like a whole code, and now it's gone. And we didn't know they didn't know what to do with that, nor do we. And so I think there's a lot of principles we can learn from taxonomy. Again, this is just a slide that says what its purpose was, to describe biodiversity. My reason for showing this is that I think we need to wrestle with some of the concepts in the taxonomic literature as we go through new definitions and new subtypes. Now, they're not immune to their own problems. So there's this dude, Robert Hoser. And if there's anything you do after the lecture, please go Google this guy, because it's an amazing story. He's in Australia and has, this is sort of like his CV. Over the course of his career, he's identified 25 species, 53 subspecies, 113 genera, all these types of things of snakes. He's named some of them after his pets, after his mistress, his wife. It's really incredible. And so in taxonomy, there's this sort of this principle or priority principle where when something's named and a species or a clade is identified, it is a thing. And it can't be unthinged, like it is there. And there's quite a bit of conceptual turbulence and descriptions of taxonomic vandalism, such as this case. And it kind of makes me think a little bit about some of the science we're doing in our sort of sepsis subtyping. Okay, so there's some problems with subtypes. We can approach these in a very simplistic way and say, well, it's either A or B. It is hyperinflammatory or it is hypoinflammatory ARDS. You get one or the other. But the truth is that sort of the idea of a discrete group is a fallacy. It's Instagram versus reality. And we see this sort of, in taxonomy, you're either a bird or a mammal, but there's the platypus that is kind of both. It has eggs, it has all these other things. So, and this is shown in the data when you look at probabilities of memberships to groups in some of these phenotyping papers. You can see here in the bar charts on the right that have a color to them, there are members with rather moderate probabilities of being in a group or in a phenotype in quite overlapping regions. It's also interesting to look then what happens to the people on the margin of a group versus in the center or the core. And in this bar chart, of course, the marginal patients have this higher proportion on the y-axis of changing groups over the next 48 hours or so. And in fact, you even go one step further in the process trial when we look at people who are on the margin of a group versus the core, shown in panels E and F. They actually have very different treatment outcomes for oligotherapy if they were in the so-called delta group, but they were like really delta versus kind of maybe not so sure. And a number of groups are thinking about sort of these memberships as a continuum and what that means for subtypes. So I already touched on this a little bit, but of course they don't stay the same. There are instances where we've thought maybe ARDS subtypes are stable. But I submit to you that that's just because of the way the data was collected in those studies. If I have a case report form on day 1 and a case report form on day 3 with lots of the same variables, it's likely that those patients are going to look and resemble the same. However, in electronic health record data where we have much more frequent measurements, we can see that sort of sepsis groups are perhaps changing over time. And you might not be surprised. This is either the natural course, the response to treatment, the resources available in that facility. And your first thought is, well, then those subtypes must not be true. But I again submit that this is still an area we have much to learn about and how it relates to our treatment effects. So again, in the interest of going quickly, I'm going to sort of try and end this sort of philosophical discussion with this bit. And that's that there is no consensus. So again, a Kandinsky, circles, right? A very famous abstract painting of his. There's many more rows to this, of course. But what I've shown are some examples of sepsis subtypes. There's those perhaps from Tom Vanderpoel's lab, the MARS. There's the sepsis response signature that we heard from Anthony at the roundtable discussion in the opener from Emma Davenport and Julian Knight. There's ARSENICA clinical, and these all come from different data sources and different trials. And so they're all attempting to make circles, but they all kind of look different. And then naturally you say, well, do they agree? Should they agree? Well, this is Lonneke van Bocht. She's a now mid-career scientist in the Netherlands with Tom Vanderpoel and Joost Verzinga. And she's actually put these on the Mars cohort and said, well, let's look at SRS, Mars, all of them together, and whether they agree. And so this alluvial plot that is on the right-hand part of the slide, the left column are clinical subtypes, The right-hand column are the, quote, endotypes, Mars 1 through 4, and the sort of the ribbons correspond to proportions of patients that are in one group matched to the other. And you'll see that they all cross. And there are about 100 more plots that she's made like this, showing that none of them, in fact, agree. And I think this lack of correlation and agreement, perhaps, is the main opportunity here. If we were speaking in front of sort of breast surgeons or breast oncologists, they would say, well, of course, patients that have a HER2 receptor mutation don't match my patients with abnormalities on their mammoprint. That's because I need both when deciding if I'm going to give them treatment A, B, or C, sort of like all of the mutations that Gordon was talking in AML. Okay, another example, this is data from Nate Shapiro, 100 patients in Boston, gene ontology plots, again looking at Hector Wong's classifications with those from ARDS and others, again, no agreement. Okay, so instead of perhaps taking one set of phenotypes, dumping it on some clinical trials, and looking for a whole host of treatment effects that have very disparate biologic mechanisms, or looking in observational studies, as we've done with Mars and SRS, where we lose the protection of randomization, I actually think we need to be thinking about subtype ensembles and putting these together to learn consistent patterns. And there are folks who have, of course, again, done this in taxonomy, and folks that at least in our colleagues in oncology have looked for these sort of pan subtypes using machine learning methods again, or clusters of clusters. So this is where the science, I think, is heading in our subtype space. I would absolutely hesitate to propose that Seneca was the end. Those type of clinical subtypes are merely the beginning because of all the limitations we've discussed. So to wrap it up, ahead of time, sepsis is not all the same. There's hundreds of subtypes proposed. There's heterogeneity in membership, in time, and major challenges that relate to consensus, the absence of discrete groups, movement over time. And I think the future would really be driven by notions of ensembles and curiosity. So thank you.
Thank you, Chris. Great talk. Questions from the audience? Gordon, go ahead.
Chris, that was marvelous, as always. But at the end of the day, right, what I think we're all heading for is therapy, right? Like at the end of the day, and is it the case that every one of these needs to be validated? Like, are we going to say this is an important phenotype, or an important, I guess I'm going to say now, ensemble of phenotypes? Is the only way to say that it's important when it responds to a therapeutic intervention? And if that's true, I see you're nodding your head, that's good, kind of, sort of. Is there another way to tell if they're important?
That might be depending on what hat you're wearing. So I think in some ways, there are folks that want their subtyping approach to be reinforced because there's other stakeholders at the table. There's the funder, right? There are the employees. There are all of these. So there's those sort of motivations. I think if there was an independent set of folks, remember in zoology and taxonomy, there are international consensus organizations that set forth criteria for these. Because of the Hoser problem, that they might be looking for, plausible biological mechanisms that separate a group, morphological differences perhaps. But if you're an alternative clinicians, they might say, none of this shit matters if it doesn't affect what I'm doing to my patient in front of me.
But I wanted to push you to then tell us the other ways to validate the ensembles. Like, is it the case then that we take an ensemble and then we identify the patients and we show them to clinicians and say, do these look different to you? I want to know what the validation arm is of you've described beautifully a discovery arm. And I guess I'm pushing you on what the validation piece is.
Yeah.
How do we know that after we've got the ensemble of phenotypes or the collection of ensembles of phenotypes, how do we know that it's a good one?
Yeah. That's a good question. I don't think, so I recoil to the word validate, first of all, but then I would say there sort of the understanding of its importance relates to reproducibility, biologic plausibility, and treatment response.
Because if it is treatment response, the hard part about that, of course, is randomized trials are expensive and take a long time. And if the importance assessment, I won't use validation, if the importance assessment comes down to a clinical trial, holy cow,
Holy cow.
holy cow.
But it's happening. Right. Precision trials are in the work, are happening. So, yeah.
Great.
Thank you, Gordon. Thanks.
Thank you for the perfect bridge to the next talk. Professor Taylor Thompson is going to present about bridging the gap for precision medicine, and hopefully will answer all of these questions for us in just 15 minutes because we are running late.
Copy that. Thank you very much. And on that note, Gordon, let's talk about some trial designs to try to get at this. All right, these are the conflicts. I enjoyed sitting in the back, well clear of the shrapnel. This morning's session was just lovely. Thank you, guys. So we're going to do two things. We're going to talk about promising avenues for better studies to help us unpack this heterogeneity and perhaps give it some meaning. And talk a little bit about master protocols and platform designs, get in little weeds a little bit. All right, the first point I'm going to make about better trials is we need better reporting of heterogeneity of treatment effect. We saw a good example of that with Ewan Gallagher's presentation at the plenary, unpacking the anticoagulation issue in COVID. And what do we mean by this? Well, we've, for many years, over-relied on the average treatment effect. Dr. Roca made this point. And traditional analyses of one variable at a time are underpowered, have a multiplicity problem, they're not hypothesis-generated, prone to false positive and negative, and they don't provide patient-centered estimates, as many patients have attributes that simultaneously affect outcomes in treatment. That is to say, there's some hidden heterogeneity. Now, to make this point, Mike Pancina and I, in a piece in New England Journal Evidence, introducing a new series, gave an example of how we might not only use heterogeneity of treatment effect to find treatment-responsive subsets, but we might use it to make individual patient decisions. And we use the dual antiplatelet therapy experience. As you know, this is after PCI. A couple years later, there's a difficult question. Continue and accept the risk of bleeding, or discontinue and accept risk of restenosis. And so there are two risk models that have been built, a risk for bleeding and a risk of ischemia. They have reasonable discrimination, a C-statistic of around 0.63 for each exactly. So not so good. But if you combine them, consider this little plot. You have in the upper right panel, you're at higher risk for ischemia and higher risk for bleeding. Well, duh, time to stop. And in the lower left panel, you're at lower ischemia and lower risk for bleeding. Sounds like you probably should continue. And then you've got two where you have an ambiguous result, and then you have a conversation with the patient. And I'll just let you use your imagination of how many of these trade-offs we have in critical care. And perhaps better reporting of our trials would allow us to make some of these nuanced decisions. So we now have a path forward, pun intended. This is the path statement. David Kent has been thinking about this for years. He defines heterogeneity, a treatment effect there. I'll let you read it. And proposes a framework for looking at this through two approaches, risk modeling and effect modeling, and asks that the broad community accept this approach to clinical trials. Better yet, embed this approach within clinical trials. Recommended reading. Now, the other getting smarter about clinical trials point, and I'll make it briefly, is that many of our molecularly targeted drugs may benefit a subset, and you may not be able to see this with broad eligibility criteria, and there's a long history of this. Biomarker adaptive threshold designs, these are from Friedland and Simon at NCI, combine a test for the overall effect with a validation of a predetermined cut point for identifying a sensitive population in a single trial. We need to start doing this. This preserves power to detect small overall effects. Basically, and I'll skip the next slide to make this point, if your prior suggested about a third of the patient are going to have most of the effect, then just pre-specify that. It's free, and you may be able to a priori identify a responsive subset. This is just the operating characteristics of a simulation, and I'll just pass on that. This is a big space in a number of fields, and as we move into this precision medicine era and we need to validate our biomarkers, we should be thinking about this. All right, so let's move on to master protocols and platform trials. First, let's talk about biomarker credentials. We're going to use these trials, and they were originally designed for targeted therapies, and we're going to incorporate biomarkers in these to try to find treatment-responsive subsets. This is again from Friedland and Korn, and it talks about how these trials might look. If you've got a solid biomarker where you've got convincing evidence that only biomarker-positive patients benefit, that is the trial designed for you. Nothing comes to mind in critical care that has that kind of credentials. Alternatively, if you're thinking about, well, is Mars 1 or Mars 2 or Mars 3 or Mars 4, are they treatment responsive? You're going to have to look at all of those with a corresponding placebo. And that would be the trial design if you're trying to validate a biomarker. So if you only study biomarker positive, you don't answer the question of whether that biomarker has predictive validity unless you also test it in the biomarker negative group. So this is an example of a trial then on the panel B. And such a trial can be enhanced by response adaptive randomization. If your priors are biomarker positive is where the money is, you can probably play the probable winner, and this is what was done in the BATTLE trial, personalized therapy for lung cancer some years ago. All right, so these are the definitions of the various trials from Liza Lavange and Janet Woodcock. And an umbrella, multiple therapies in the context of a single disease or construct. Basket trial, single targeted therapy in the context of multiple diseases, and a platform. You can read that. Now, notice there's two words that are repeated 3 times: targeted therapies, targeted therapies, targeted therapies. This whole approach to clinical trial design was originally conceived to test targeted therapies. So let's drill down on some of the specifics on how this might look and see if this ensemble that Chris talked about might be identified going forward. And I'm going to use treatment response as an example. So this is a schematic out of the NHLBI workshop on advancing precision medicine for ARDS. This is an ARDS-specific platform trial. We outlined a construct for it. And let's drill down on this a little bit. So this is ARDS, and we have treatment 1, 2, oops, let's go back. How do I do that? There we go. What? So let's, so we have ARDS, we have treatment 1, 2, 3, 4. 1 disease, 4 treatments. That's an umbrella, right? But what are those little arrows under each treatment? What are they meant to be? Those are meant to be 3 strata within each treatment. So we're going to give hydrocortisone for alpha, beta, gamma, delta types of sepsis. Well, wait a minute, that's 1 drug and 4 subtypes. That's starting to sound like a basket. Well, that's correct. This is a combined umbrella and basket trial, and many of these platforms combine both approaches. Now, these trials have a master protocol, and this particular master protocol could have domains of how to set the ventilator, how to use repurposed drugs like statins and steroids, or it could have brand new drugs in the registration space, and they could all play together in the same sandbox. What about the biomarkers? Well, the biomarkers would be suitable for the research question. They could be a protein biomarker, latent class, transcriptonic class, Seneca class, physiologic classification based on dead space, elastance, focal, diffuse, doesn't matter. And again, all of these could be in the same platform. or they could be in a multi-platform approach, and if that's the case, they should be talking to each other. In this construct, we're going to have to make a decision if we're in a phase 2. Is this drug have potential for phase 3? That is always a complicated decision. Recent studies have used multidimensional modeling and used the posterior probability of success in phase 3 as their readout in phase 2. And a Bayesian technique is required for that. And I think, quite frankly, a Bayesian technique is more suitable for many of these questions. And they have shared controls, which have a lot of interesting features which we will not get into. So this is a platform trial for ARDS. And I'm going to finish with 2 slides that try to answer this question. Do we need separate platforms for each of our beloved syndromes, as for REMAP-CAP? Or could we use this approach to sort of unpack all of this? And let's take a lesson from, or an example from cancer. Here we have basket trials for so-called basket indications shown on the left hand. We have 3 FDA-approved drugs for agents that are histology or tumor agnostic. The lower one came from the NAVIGATE trial, which was a basket trial that enrolled 11 different tumor types for the study of an NTRK inhibitor. 11 different tumor types: thyroid cancer, breast cancer, so on and so forth. And this developed a tumor agnostic indication. Well, let's just do a thought experiment here. Here is a schematic from David Maslov and John Marshall and many of us, conceptual notion of how the inflammatory response to pancreatitis without infection, infection, surgery, and trauma may overlap. And these bands are meant to show, for example, this red band, that there may be common biological pathways in our beloved syndromes. Well, let's just imagine that we have a drug that blocks this pathway. Let's call it cleverly drug D, and it's linked by biomarker D+. We could then do a basket platform trial for identifying D-positive critical illness. And we would be enrolling into this trial pancreatitis, trauma, surgery, and infection. Now, because this is an ARDS session, let's give another example. Does the hyperinflammatory host response to critical illness have predictive enrichment across syndromes? Now, Carolyn Calfee's work in ARDS have suggested there's this hyperinflammatory subphenotype. Well, guess what? You also see it in community-acquired pneumonia. You see it in COVID-19. You see it in acute hypoxemic respiratory failure, including an acute exacerbation of COPD. You see it in heart failure on a vent. So the question would be, and what Carolyn has shown, is differential treatment response to fluid, statins, and PEEP in this hyperinflammatory response. Now, I'm not saying this is ready for prime time in such a study, but when we understand this a little bit better, this kind of a trial could develop a syndrome-agnostic indication for a drug or a process of care. And the trial would enroll CAP, sepsis, respiratory failure, ARDS. Complicated, there's a lot of overlap here, a lot of logistical. But I would say, Gordon, I'm with you on when these syndromes or constructs get legs is when we've identified that they're a treatable trait or there's a treatable trait hidden within them. And this is the pathway to finding those, or one pathway. So let's conclude, wrap it up. Analysis of HTE and RCTs, risk modeling or effect modeling is more likely to identify treatment responsive subsets if indeed they're present. They may not be. And has the potential to guide individual treatment decisions. Biomarker adaptive designs should be considered for the reasons I said. And for platform trials, I hope I convinced you that the design should suit the purpose. A better understanding of the biology of ICU syndromes and the identification of linked biomarkers are needed. So when Chris develops these syndrome ensembles or subset ensembles, I'm going to be looking for drug targets in that ensemble so we can gather them up and study them. And this is an enormous cost and effort, especially in phase 3. It should be global. Thank you.
Thank you so much. Brilliant talk. I have questions. Time for one question.
Yeah, clinical trials are about as exciting as, designing them is about as exciting as watching paint dry. All right, very good, thank you.
Thanks. Great. It's our next speaker is Dr. Nuala Mayer. Nuala is going to speak to us about treatable trait in ARDS and sepsis.
Thank you so much for the invitation to speak. Great. So a few disclosures. My intellectual conflict is that I do believe in treatable traits, and one of the advisory board members is trying to develop a companion diagnostic. So we just saw this really elegant figure from I think a highly influential paper that was conceived of and led by David Maslov and John Marshall, who you'll hear probably a lot more about this next. But Dr. Thompson really highlighted how perhaps we could, perhaps we could envision kind of this red dot as a shared trait that we could see across multiple syndromes. And I think we've all experienced this as ICU clinicians, where we might have a severely injured patient who we did not think was infected, but was manifesting dramatic vasopressor-dependent shock and fever and inflammation, and wondered whether we should adapt some of our sepsis treatments. So maybe we could term those treatable traits once we find the treatments that work. And I really liked this concept that was put out in a review of treatable traits within obstructive lung disease. But trying to break down, we know that there's tremendous heterogeneity in obstructive lung disease, and yet perhaps patients that share certain features like eosinophilic inflammation might be predicted to respond differently to therapies. So when we're talking about treatable traits, we're looking for traits that are clinically relevant. They have to mean something. So whether that's that they respond differently to treatment or they have a different prognosis, both could be useful. They have to be measurable, identifiable. Eventually you have to operationalize those and say, what does a positive troponin mean? And is that context specific? And of course, they have to be treatable. So we'll go through a couple of aspirational examples from other complex traits and ask what we could adapt. I'm deliberately going to eschew cancer a little bit because I think that's a very different example that has pathology to guide them. We'll look at our successes in sepsis and ARDS and ask how close we're getting and what could we do to accelerate future success. So just last week's New England Journal has the new poster child for precision medicine, and this is an incredibly scientifically elegant description that leveraged the knowledge that, especially in the United States, we recognize that our patients with African ancestry have a huge increased risk for chronic kidney disease compared to patients of European ancestry. And so leveraging genetics, we were really able to pinpoint this risk to variants on the APOL1 gene. And these variants were coding, they changed the protein sequence, and they were private to African population. So up at the top in red is kind of showing you the distribution of these, where these genotypes are found. And like I said, a huge risk. So odds ratios of 29 for some of these traits, especially traits that caused heavy proteinuria. So that led to a lot of investigation. Why would APOL1 be involved in kidney disease? It's a channel. It changes your potassium flux. Knowing that, scientists were able to do small molecule drug screening, looking for how could they modify the APOL variant. They then did elegant animal studies. They could actually use CRISPR-Cas to knock in the human variants and use that as a model for their drugs and ask which drugs could influence this mouse. And it culminates in a 15-patient trial, genotype-directed trial, phase 2, single arm, all patients got the drug. And they had a great readout of proteinuria. And showing you here the 13 patients who met their a priori adherence criteria, 12 of the 13 had dramatic reductions in their proteinuria. One patient did not respond, and they're trying to figure out why that is. But this is a genotype-guided trial with a really solid rationale with beautiful biologic. And I think worth noting, isn't it nice to see this type of effort and money put into a disease that affects our African ancestry parts of the world, which have historically been underfunded. Our cardiologists have been able to leverage genetics very effectively. So they focused on LDL and could use that as a quantitative trait, which then has a lot of power statistically to do genetic screens and say, what are the genes associated with LDL? And look at how many of these have kind of been converted to therapies. So we now have PCSK9 inhibitors because we understood that patients who are PCSK9 null have dramatically lower LDL. There are new gene targets looking to silence the sortilin gene. ApoE is another target. So how were they able to make these advances? Because they had defined causal traits. They used causal inference to show that LDL mattered for MI risk and MI mortality. It was quantitative and therefore statistically powerful and easy to bring back to the clinic so we could measure LDL on our patients and develop those cut points. And it really clarified their therapeutic goals. Lots of other examples in other complex diseases. But again, if we think about what we're trying to achieve, we would like in sepsis and ARDS to find our causal drivers. We'd like to know what quantitative traits could help us get to those causal drivers. And then, maybe there are some tools that would at least help us sort our patients, whether we're sorting by prognosis or by treatment. So our group used a small genetic screen, really, in retrospect, and found a fairly consistent relationship between a variant in the interleukin-1 receptor antagonist gene and lower risk for both ARDS and sepsis death. It seemed to be a functional variant that caused you to make IL-1RA faster, and that could subsequently perhaps suppress your IL-1 beta. And of course, that was interesting because people had wondered about blocking interleukin-1 beta with synthetic IL-1RA in sepsis and had done several phase 3 trials that did not have a large effect, not a large average treatment effect, maybe we'll say. But we wondered, seeing this heterogeneity, both genetic and in the plasma proteins, maybe this effect might be different in patients with different IL-1 dysregulation. So I was fortunate to collaborate with Stephen Opel, one of the PIs from that sepsis phase 3 trial, who still had samples left over, 20-year-old samples from the freezer. We were not able to genotype them. We tried to do whole genome amplification. That didn't really work, but we were able to measure plasma IL-1RA and plasma IL-1 beta. And we identified a statistical interaction between the mortality effect of this randomized drug and your risk for mortality, and where you were in terms of your IL-1RA expression. And whether we did that as a single cut point or looked across multiple cut points, looking at deciles of IL-1RA, we saw this. We didn't think we were just identifying severity of illness and that we did not appreciate the same interaction for Apache by itself, looking at different Apache strata. And this was our rationale to go ahead and do a stratified analysis, stratifying by IL-1RA expression. And hopefully you can see here in red are the patients with high plasma IL-1RA who have a mortality benefit from being randomized to recombinant IL-1RA, whereas in blue are the patients with low expressing baseline IL-1RA who, if anything, seem to do worse when they're randomized to recombinant IL-1RA or anakinra. So is this a treatable trait? Do we have high plasma IL-1RA as a treatable trait? I would say not yet. So certainly we need first a qualified IL-1RA assay that works the same in different contexts. We definitely need prospective replication in a contemporary setting. That was 20 years ago. And I'd argue this is good rationale to retest IL-1RA. And adding to that might be the SAVE-MORE trial that in floor patients with COVID, again, seem to appreciate an effect. So I'm advocating for more testing. If we think where we are in sepsis, so we've done very well on the classification side, and several different groups have come up with whole blood gene expression classifiers. So these are looking at the messenger RNA expressed by all of your circulating white blood cells. The Knight and Davenport group reported the sepsis response signatures. The Mars group from the Netherlands had Mars 1 through 4. And Tim Sweeney's group integrated a lot of large data sets, including the other twos, and came up with 3 clusters that seem to replicate in a number of populations. So interestingly, the sepsis response signature has been tested at least in one subgroup of the VANISH trial. David Ancliffe and Tony Gordon went back to their VANISH patients who still had a PAX gene tube or whole blood gene expression, and were able to show that SRS2, which is typically the very low mortality group, when randomized to hydrocortisone in red, had a much higher mortality, suggesting there is harm in these SRS2 patients from being randomized to hydrocortisone. Now, that was a randomized study. However, it is a very small number of patients because it was a subset. And with small numbers, we always have to be worried that our results might be more extreme than truth. So I would say, again, maybe this is a treatable trait. I'd like to see it replicated in a larger study to be more confident that this mortality difference, which is so large, is repeated. We heard about ARDS subphenotyping and hypoinflammatory, hyperinflammatory, or of course, Dr. Boss's group that did the reactive and uninflamed. These 2 phenotyping schemes share a lot of similarities, with plasma protein expression being the real drivers. And certainly Dr. Calfee's group have shown heterogeneous treatment to randomized PEEP, to randomized fluid strategy, and to randomized simvastatin. So is hyperinflammatory ARDS, is that a treatable trait? Again, it's measurable. We think it's significant based on both this differential effect and the mortality. But can we prospectively validate it now? And so I think there are several efforts, including the FIND study, to try to do just that. So what do we need to do going forward? Like I said at the outset, I'm a believer and a Ted Lasso fan. But I really think we need to find those quantitative traits. Those numeric traits are just so valuable in helping us to find those biological signals. Wouldn't it be great if we had an LDL for ARDS or for sepsis and could really clarify some of our therapeutic efforts? Once we have those traits, we really need to test their causality and or their ability to consistently classify patients. I probably didn't stress this enough, but a lot of the advances that were made in asthma, in cardiovascular disease, leveraged the randomized trials that they already had. That's really our only way to test what is treatable when you can use randomization. So I would really recommend that we always try to include biosamples into the majority, if possible, of our patients enrolled in trials. Thank you.
Thank you, Noala. Questions from the audience on this topic? No? So can you, in parallel with the studies done in COPD and asthma, where the treatable trait concept was sort of developed, do you think we need to be a little bit more pragmatic about what we call a treatable trait or not? Or do we always need prospective randomized control trial validation? As an example, in asthma, nasal polyps are considered to be a treatable trait because in associational studies we know that if you treat the nasal polyps, then asthma control is slightly better. So we treat all the patients' nasal polyps with local corticosteroids. But this has never been shown to reduce exacerbations in prospective randomized controlled trials. Should we learn from that, or do we have a higher standard in intensive care medicine?
Ooh, I do not think we have a higher standard. I think we will take any treatable trait we can get. And I would actually say that in asthma, maybe part of your question is, does it have to be a molecular trait to be treatable? Absolutely not. We will take radiographic traits. We will take clinical features. It's just that to date, those clinical features have not typically translated easily into a treatable trait. But if we can find those, absolutely. And then otherwise, I would say asthma is so interesting that asthma and eczema and other atopic diseases, they are a basket, right? Where we have treatments that work for all of these. We all think eczema is quite different from asthma clinically, but they might share a treatment. So I would like to develop both.
All right, thank you very much. Next speaker no longer, sorry? The next speaker no longer needs introduction, I think. We've seen the paper you're going to talk about already 2 times. Professor John Marshall is going to speak about redefining critical illness.
Many thanks, Louis. After listening to those last 2 talks, I think a lot of the points I wanted to make have been made, and much more clearly and much more elegantly than I'm going to. So I'm going to be able to go through some of this fairly quickly. But what I wanted to start with was the concept here that if you look at these 2 patients, I suspect nobody in this room would think they have the same disease. But they might. They might both be 2 patients who were hospitalized with pneumococcal pneumonia and had very different responses to it. They might be somebody who came in with cardiogenic shock on the one hand, or somebody who's recovering from glaucoma surgery on the other hand. Whether you have the same disease or not depends critically on how we happen to group patients. And how we happen to group patients, I think as we've heard repeatedly this morning, is very much contingent on what it is we can do based on those particular groupings. So we have a particular problem in critical care, and that is that we are dealing with diseases that, first of all, didn't exist before 1950. Because they only became possible with the advent of the capacity to support patients who otherwise would have died. And they are complex in that they involve an interaction between biology, and it's usually the biology of the host response, as well as the treatment that patients are receiving. And so understandably, we've tried to make some efforts to characterize these diseases better. We've come up with what have been generously called syndromes, acute respiratory distress syndrome and sepsis, but increasingly we're appreciating that they're not good organizing principles when what we're interested in is identifying patients with treatable traits who might respond to a specific therapy. And I would remind you that not only are these suboptimal, they are old. Both the ARDS definition or concept and the sepsis concept are products of the 1960s. In the 1960s, we didn't even know that there was such a thing as a cytokine. We didn't know that there were kinases. There was a whole field of biology that just didn't exist at the time. And as our sophistication in understanding biology has accelerated, our capacity to group patients together has not. Here, for example, you'd see descriptors of the clinical features of septic shock. We haven't really changed those very much, but what we now know is that that phenotype doesn't necessarily imply a single genotype or biologic response process. Similarly, ARDS, described as high output respiratory failure, is a good description, but it doesn't tell you anything about what's going on biologically, and therefore it has proven refractory to efforts to try to treat it. And we've achieved sophistication in definition, but I think we've confused that sophistication in definition for progress in actually understanding what we need to do to treat patients. And I do think that it's critical that we look critically at what we have been doing and find better ways of organizing things. We use the word syndrome quite loosely in critical care, but I think it's important to recognize what a syndrome is. It's a group of signs and symptoms that characterize a disease process and point to a common underlying treatment. Down syndrome, for example, was described in the 1860s by J. Langdon Down, who recognized these strange facial features and limited intellect in a group of patients and saw this as a syndrome. But at the time, nobody knew there were chromosomes. Nobody knew what DNA was doing. There was no biologic basis for the disease. And so the syndrome was purely descriptive. As it turned out, that description was able to characterize a process that had a single biological basis, and that was trisomy 21. But I don't think the same thing holds for the very complex disease processes that we treat, and we have to step back and find new organizing principles. So this is from this paper that a number of us put together last year. There is an evolution in critical care. The first period of time, the 1960s, we were in awe of what was kind of emerging, at what happens when you keep somebody alive on a ventilator in an intensive care unit. And syndromes began to emerge. Following that, we tried to define the physiology better. We tried to be more precise in the description of those syndromes. But it didn't translate into new therapies. And so I think we're now on the precipice of an era that maybe one could call precision critical care. I think that's probably not adequate, but where we need to move beyond syndromic descriptions and try to understand biologic abnormalities and how they group together so that we can then treat patients. So we're really moving from a concept that patients die from the host response to trying to define syndromes, within those syndromes perhaps to try to define diseases. And this was the idea behind this, because there is heterogeneity. It is the essence of critical illness. But that heterogeneity is not only within syndromes, there's homogeneity across those syndromes. And that's what this graphic is intended to show, that there will be features of disorders that don't seem anything alike clinically, but they actually share a common biologic basis and could be grouped together for purposes of evaluation of treatments. That heterogeneity in critical illness is extraordinarily complicated. It comes from so many sources. It's not just biologic heterogeneity. It's not just heterogeneity in the disease the patients come in with. It's the comorbidities they bring. It's the support we provide them, the clinical care, the iatrogenicity of providing care. It's the genetics. It's even the microbiome. There are huge influences that we're just beginning to understand about how changes in the microbiome are actually changing the capacity of the patient to respond to a treatment. And that heterogeneity impacts two things. It impacts the risk of having an adverse outcome, as well as the potential to respond to treatment. And I think sometimes we tend to conflate those, thinking that if we can predict who's going to live and die, we understand a disease better. On the other hand, it is important to know and to be able to recognize that severity itself can be a determinant of heterogeneity and responsiveness, as was shown in this very nice analysis of data from the REMAP-CAP trial, showing that heparin treatment effects vary contingent on disease severity. And even unpacking that, I think, becomes a source of significant new insight in critical illness. We see this as well in classical sepsis. These are data from the MONARCHS trial of an anti-TNF antibody showing enormous variability in levels of tumor necrosis factor, but equally variability in treatment response stratified by interleukin-6 levels. So unfortunately, this didn't work out as it was originally hoped, where patients were stratified by a much lower IL-6 level of 1,000 picograms per mil. But I think it's a nice tantalizing suggestion of how we might be able to better refine groupings of patients and therefore see larger and more clinically important treatment effects. We've seen these data, and I won't go over them, another example of variability in response to intervention. You see the same thing in animal models where the consequences of neutralization of tumor necrosis factor are model dependent. So it's good to neutralize TNF if you're giving a mouse gram-negative bacteria or endotoxin, bad if they've got pneumococcus. It actually increases the mortality rate. Now, I mentioned that there's heterogeneity within diseases, but there's also homogeneity across it, and homogeneity in targets. In patients with multiple trauma who are admitted to an ICU, after they've been in the ICU for several days, some of them become endotoxemic, and those patients are more likely to have adverse outcomes. And so in an anti-endotoxin trial, a plausible and substantial population that could be targeted is those patients who develop endotoxemia following multiple trauma. But you would never find those patients if your organizing concept was we need to treat patients with sepsis. We are seeing other diseases, even as remote as rheumatoid arthritis, which share biologic mechanisms with critical illness. And TNF, for all the effort we put trying to show it would help patients with sepsis, has become standard of therapy for rheumatoid arthritis. And indeed, one thing we've learned in COVID-19 is that those things that work in rheumatoid arthritis seem to work in COVID-19 as well. And so we're actually seeing almost a kind of reverse translation where we take therapies that were effective in patients with rheumatoid arthritis, and they now become plausible interventions for patients with critical illness. So I've been a bit negative about the concept of syndromes, and I don't want to imply that they have no utility. I think thinking and grouping patients by syndrome has been helpful. In sepsis, we have really underlined the importance of resuscitation and really underlined the importance of looking for and treating a focus of infection. The syndromic construct allowed us to do that. In ARDS, we have really gained because we've understood the importance of how we support a patient with a mechanical ventilator as being a determinant of how they ultimately do. But what we've not done is leverage these syndromic constructs to develop pharmacologic therapies for the abnormalities that some patients with these diseases ultimately have. So putting it another way, I think where we sort of started was we'd said, look, there's a whole bunch of people who come into the intensive care unit and they're critically ill. Maybe we can look at them and divide them into more discrete groups. This is going back to the 1970s. So we said, okay, yeah, there's some patients with sepsis, they're one group. The patients with the ARDS, they're another group. And partly it depended on what your specialty was and what your interest was, which group those patients went into. There could be patients with multiple trauma, others, and then we used those populations to run clinical trials, and recurringly we were disappointed. But I think we need to look at this the other way around. We can say, look, there are patients who meet criteria for sepsis. Many of them will get better very quickly. Patient with cholangitis, when you put a tube in the bile duct, the patient will be recovered to the point of almost being able to go home the next day. But some of them progress to critical illness. Some patients with trauma get better very quickly, but others progress to critical illness. I think we need to step back and think about as a very, very broad organizing principle for moving towards this more precise definition of treatable trait, that critical illness itself is the best organizing principle. And within that, we will find people who have, for example, a capacity to respond to Bruton's tyrosine kinase inhibitors or to some form of anticoagulant therapy. But I do think we need to reorient our thought. This was that paper, and the schema that kind of came out of that is there is a path forward to doing this. That is to recognize the commonalities across syndromes, use machine learning approaches to try to group together some of the features of these so that we have more homogeneous patient populations, and then undertake studies of interventions that modify that biologic pathway in that particular group of patients. Put them on a platform trial. Recognize that this has to be iterative, it has to be done at grand scale, and it has to be done over a period of many, many years. This is not something that can be accomplished with our current, small approach to doing clinical trials. But I think it is the route forward to achieve some success. So I think we've learned three critical factors. One is that heterogeneity in critical illness is multidimensional, and we have to be able to better describe that heterogeneity and figure out how we group it and how we separate patients on the basis of that. Biologic mechanisms that we're coming to understand much and much better can be common across varying syndromes and across this heterogeneity. We need to figure out how to identify patients who have those common biologic mechanisms, because it's those mechanisms that we target therapeutically. And I think perhaps most importantly, and this has been a huge lesson of COVID-19, is that you don't do this by running my trial versus your trial, in my country versus your country. We really need to figure out how we put all of this stuff together into a common, grand initiative to deal with the problem of critical illness, much as workers in other fields, and you can think of particle physics or climate change or oncology have done. I think it really is the challenge for our specialty as we move forward. Thank you very much.
Thanks, John. Fantastic talk. Are there any questions? Right. Can I ask a quick question, John?
Of course you can.
So, if we go down the route of turning it upside down and starting with critical illness, are we still hoping to retain some of the things that we spoke about, which is subphenotypes and endotypes?
Absolutely. Yeah. Well, my point is not that we go back that way. It's just where do you start? And rather than talking about heterogeneity in ARDS or heterogeneity in sepsis, let's go back and say, okay, the heterogeneity is in critical illness. It's the sepsis 3 definition has put the emphasis on organ dysfunction. And that's, I think we need to expand that broad pool that we draw things from, but not go back to studying critical illness as an individual event. It's within that we have to move forward.
Thanks very much, John.
Yeah, thanks.
If there are no questions, it's a pleasure to invite the next speaker for our session. That's Dr. Michelle Gong, who's going to discuss let's better define clinical trajectories.
Oh, thank you. Let me just make sure I know how to advance the slides here. Okay. Oh, there you go. All right, as the last speaker before lunch, I'm very conscious of the time, and I salute those of you guys who decided to stick it through to the end. I have no disclosure relevant to this particular talk. I'm going to take a slightly different bend than the previous talks that have been presented so far. You know, a lot of it is talking about criterias for ARDS, for syndromes, subphenotypes, that are at one point in time that says, once you meet this, you're there. I'm instead going to talk a little bit about a more longitudinal view of whether or not clinical trajectories may be more relevant than, say, a syndrome and anything at one point. So why do I say that? So we all know the severity of illness is predictive of mortality in the ICU by organ failure, for example. But actually, what's more important is not so much how sick you are at the beginning, but how you respond during the first 24 to 48 hours in the ICU. And if you look, actually, the mortality of those in which their organ failure score improves is actually quite low. It's about 6%. And most of the mortality is actually coming from those whose SOFA score either didn't change or got worse in the first day or two. And that's true also if we look at Apache. Worsening Apache, worsening mortality. And this is intuitive, right? This is what we do when we treat patients, that we're always assessing to see actually how are they responding when we first treat them and what that might mean for their prognosis. But this concept, this impression that we have was so smartly quantified by Ed Schenk and his group, where he looked at dynamic time warping to look at distinct trajectories of organ failure over the first 3 days of patients admitted to the ICU with sepsis. And he defined actually 4 clear groups. There's the rapidly worsening group, which is the red line, rapidly improving group, which is the green line, and then there's the delay worsening and the delay improvement. And what he found is that the rapidly improving group has the best, highest survival. But they also were characterized by less mechanical ventilation, and they also had the highest SOFA score when it came in, but also more UTIs. And the rapidly worsening group had the lowest survival, and one might think, okay, that might mean that they're improving from their acute injury of sepsis, ARDS, or whatever it is, but they also had the highest comorbidities with worse LFTs, platelets, and more acidosis. And when you think about it, when we do trials, we often actually exclude patients with liver failure and some comorbidities because actually they don't do well in these trials, but also maybe because actually it correlates with worse organ failure and worse organ failure trajectory. And even the rapidly improving group, it actually accounts for 21 to 36% of the total mortality that's seen. So it's not necessarily a benign group. And he's found the same thing actually when we looked at COVID-19 who are intubated and went to the ICU. And you can see this rapidly improving and rapidly worsening group, and that's true irregardless of what the initial severity of organ failure was at the time. And he may be able to predict this of the first 6 hours of data in the ICU. So is it possible to replace syndromes in acute critical illness with trajectories of organ failure? Well, certainly acute critical illness, as John had mentioned, is really kind of defined by the risk of progression of organ failure from whatever etiology that may have led to it. And critical care aims at preventing or limiting organ failure and promoting recovery. That's what we all do every day. It's definitely prognostic, and is applicable to many different critical illness. And it could be modified to be organ specific, right? We can actually look at the organ failure scores for the respiratory for ARDS or a cardiovascular for shock. And we've done that in crude terms. And that's what I mean by crude, because one of the big barriers to this is that we are still using definitions of organ failure that's been dated for like decades. And there's gotta be a better way of describing organ failure and its change over time. But right now, what I've talked about is only one segment of critical illness. We all know, actually, that critical illness has a continuum from when they present to the hospital to when they develop it to when they recover in the ICU and afterwards during their recovery, even at home and long-term outcomes. And it's important to understand the trajectory of organ failure during the entire continuum of acute critical illness. By looking at actually EHR data, we were able to calculate SOFA scores for every patient in the hospital over time. And one thing that we realized is actually of the organ failure that we see in the hospital, a minority of those are present on presentation to the hospital. Most of them, except for renal failure, okay, were developed during the hospitalization, which indicates actually that there is a trajectory prior to the ICU that may have led to why they ended up being needed to be admitted to the ICU. And defining this trajectory is important, especially for early intervention and prevention trials. But it's also not clear, like, how long do you map this trajectory? You know, the data I've shown you with the ICU organ failure is used basically 48 to 72 hours. But we know that organ failure persists. And actually, if you look at organ failure at 14 days, it's still present in many patients with mechanical ventilation. And that signs of persistent organ failure, like need for vasopressor, dialysis, or low platelets, is a very strong predictor for 1-year mortality. So how long do we map these guys? But there's a downside to it. The longer you map them in terms of their organ trajectory, the more you may be able to capture, but at the same time, you may be capturing mortality due to underlying comorbidities instead of the acute illness. And what about afterwards in terms of recovery? We all know about the post-intensive care syndrome. And when we look at patients, we see actually that many patients will improve after being discharged from sepsis, but that there is a plateau in terms of how much function they retain. And so many of them do not return to baseline or the population norm. But when you actually do group trajectory modeling, you see that there are actually distinct classes. There's actually a group of patients that has persistent impairment. That's nearly half of the patients with sepsis that are in this study. They barely actually improve. And then there's another group, a little bit over a third, that do improve and return actually back to a population norm. And then 14% can't be classified. And these groups actually do vary in terms of characteristics. The persistently impaired are more likely to be older, lower educational level, have more comorbidities, and tend to be married. But it's unknown right now, even though we know that actually severity of organ leads to greater impairment, we don't actually know how the organ failure trajectories may relate to these recovery trajectories that we're seeing. But organ failure is only one type of clinical trajectory we could look at. This is a study actually from the Emory Group looking at clinical trajectories of vital signs such as temperature, heart rate, systolic and diastolic pressure, and looking to see how they might relate to other outcomes. And they just found 4 distinct groups, and of those group, what they called group A, that's the yellow, and group D, that's in blue, have a higher mortality compared to the other 2 groups. They also have higher cancer and liver disease at baseline. And when they applied these groups to the patients that were randomized in the SMART trial, which is the trial that randomized patients to balanced crystalloid versus normal saline, they found that the group D patients were more likely to benefit from the balanced crystalloid in SMART. This is a similar kind of study, but this is just looking at temperature. And in the Chirpik's group, looked at the temperature trajectory of patients admitted into the ED with sepsis and found that there are 4 trajectories. There's the hyperthermic slow resolver in yellow, the hyperthermic fast resolver in green, the normal thermic in the red, and the hypothermic that's in blue. And this relates to mortality, where the highest mortality is seen among the hypothermic patients. But these patients also tend to have higher comorbidities and more use of corticosteroids and less Tylenol, as you can imagine. And they have higher inflammatory cytokines at baseline, but the fast resolvers, the hyperthermic patients, higher inflammatory cytokines at baseline, and the fast resolvers have more rapid decrease in these cytokines. But what's most interesting is that, that data may suggest that there may be prognostic enrichment and benefit to using the temperature trajectory, but there's also indication that there may be some prognostic enrichment possible with this. So this is a study that actually came out of Michigan that looked at temperature of same patients, sepsis patients coming through the ED. They were able to replicate the temperature trajectory groups that was found in the prior study. But in a subset of those patients, they also collected stool samples and looked at the microbiome and found that the microbiome differed by those temperature trajectory groups. And that if you take the ones who are hypothermic and see what was the predominant organisms in them, they found that if you take that and then you went to animal studies, you find that altering microbiome can actually change your temperature response to sepsis. So what they did is they took germ-free mice and they infected them with the predominant bacteria that they found among the patients that were in the hypothermic group, and found that they actually can change the temperature response of these mice at baseline. Similar, if you take germ-free mice that has no bacteria, they have a lower baseline temperature routinely. And then if you treat mice with antibiotics to alter their microbiome, you can actually lower the temperature response when you then stimulate them with LPS. And then lastly, if you were to take these germ-free mice and then you colonize them with the bacteria that they found that predominated in the hypothermic group, you can also alter the way they change temperature. Now, what's not clear yet is that whether or not microbiome could be useful as an intervention in sepsis by changing a patient from one group to another, and whether or not that can improve your outcome if you go from one group to another. So in conclusion, the baseline severity of illness doesn't always predict for the patients who worsen or who gets better, and that looking at distinct trajectories of organ failure may be better syndromes that we need to understand and define in acute critical illness. But if we're going to do that, we really need to think about defining the entire continuum of critical illness and understanding actually what happens before they need to go to the ICU and what happens after, and how long to map these trajectories. And vital signs is another aspect of something that we all collect and we all look at, in determining the outcomes of patients. And that clinical trajectories of vital signs like temperature may also serve as a prognostic and predictive enrichment for future trials. So with that, I want to thank you for your attention.
Thank you for that excellent talk. Are there questions from the audience? I think it makes a lot of sense to incorporate time in all of these analyses, because having just a single snapshot gives a sort of distorted picture sometimes. I do wonder, if you incorporate time, you start to see all these effects of the medication we give to the patient, the fluids, the ventilation strategies. How do you take that into account in these kind of analyses, and how do you make sense of it all?
Yeah, so there's a number of really good points there. So absolutely true, right? How your trajectory is dependent on the things that we do. So there's a few things. One is, in addition to just looking at trajectories, we really need to understand what are the other clinical factors that are leading to those trajectories and might alter. So right now, we don't have a good understanding of whether people switch trajectories. We also don't have enough high-grain data to be able to do this complex modeling, to look at actually changes in trajectories and multiple influences on what moves a patient in one to another. Third is that, if we're looking at actually early interventions, what we may be doing is needing to have these large, complex, and rich databases to define what is the common trajectories that we've seen. And we actually are needing to look ahead of time to see how well we can predict for which trajectory there is. And then actually look to see whether our intervention in a clinical trial may alter that. And so it's not so much that, during a trial, you want to look and see, if the intervention may switch somebody from one to the other, but we're looking to see actually if there's a higher likelihood of being in this trajectory based upon, what led them to come into the ICU, is then actually, after randomization, how much that can switch.
Thank you very much.